Good afternoon, everybody. Can everybody hear me? Those that are on the screen, thumbs up.
Yeah.
Hey, Dieta. Dieta, can you hear me?
I can hear you perfectly.
Thumbs up. Okay, we're going to go ahead and get started. So first of all, I saw lots of new faces and names coming through on the registration. So thank you guys so much for supporting Faith Presbyterian Hospice and the T. Boone Pickens Hospice Care Center. Today we're going to have Sue Kramer, our nurse practitioner, speaking to us. Our topic today is pain management at the end of life. Everybody should have received an email that included the PowerPoint presentation, our disclosure, and evaluation. Please make sure the evaluations are completed and sent to me by end of day next Monday, the 12th. On our disclosure that I included, we do not have any financial interest or relationships to disclose. The objectives for this educational event are listed on your eval. Requirements for completion are be present, participate. The continuing education is provided by Metro Dallas Aging Solutions. Once your completion has been verified and receipt of the eval, you will be awarded a certificate, a successful completion for 1.0 contact hours. During the presentation, please make sure your microphones are muted. Q&A will be held at the end, probably about 12:45, 12:50. So make sure you use the chat feature to ask Sue any questions you might have. So without further ado, I'm going to have Sue come here and she'll do a quick bio on herself. And again, thank you guys and enjoy the presentation today.
Hi, everybody. Welcome. All right. So I'll tell you a little bit about myself. My name, as you know, is Sue Kramer. I am a nurse practitioner. I work here at Faith Presbyterian Hospice in the inpatient unit. I've been a nurse for over 30 years, and I've been a hospice nurse and nurse practitioner for over a decade. I've seen patients in their homes, in long-term care facilities, nursing homes, and now in the inpatient unit. Okay, let's go to the next slide. It's my first time doing this, so bear with me here. Yeah, oh, there we go. All right, so in the objectives that you had, you'll be able to name different types of pain, understand what existential pain is, and we'll review non-treatment options that are available for pain management. In this presentation, as Beth mentioned, there are no sponsored entities, so there should be no conflict of interest. All right. I'm having trouble with this bar. Sorry, technical difficulties. There. Okay, so I'll just,
Is that your next one?
yeah, that's fine.
Actually, can move it to the top, right? And then you move that
Okay,
over
thank
here.
you, perfect. Sorry about that. All right. So as you see, there are 4 types of pain that we're going to discuss here today. We need to understand the 4 types of pain, which is visceral, somatic, neuropathic, and existential. Now, visceral and somatic are considered nociceptive types of pain, and what that means is that that's the body's reaction to painful stimuli. But to understand and treat pain, you also need to know what pain is. And the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage Pain is considered to be subjective, and each individual creates his or her own definition of pain based on their own experience. And in hospice, we do consider patients' pain what they state it is. We use a pain scale to evaluate the level of pain to give us a better understanding of the type of treatment or pain medication needing to be used for the patient. So we have a scale that goes 0 to 10, 0 being no pain, 10 being the worst pain, get me to an emergency room now type of pain. Pain assessment, we also have, there's an acronym called PQRST. P is palliation and provocation of pain. Q is the quality of pain. R is the radiation. Is it the pain move? Severity is the pain scale that we use, and temporal onset, such as the pattern of pain. So it's important for us to know the location and if there's any radiation of pain, meaning it's going somewhere else, the type of pain, whether it's aching, throbbing, burning, the intensity, and that's where the pain scale comes in, mild, moderate, severe, or we can give it the number. Duration of pain, is it constant? Is it intermittent? What relieves the pain? For example, taking pain medication, distracting yourself, repositioning, all those things can help alleviate pain. We also want to know what aggravates the pain: standing, coughing, moving, and do we have any symptoms associated with the pain, such as nausea, insomnia, anxiety. On an inpatient level of care, we tend to manage patients' pain with IV medication. However, at home, the options are usually oral, sublingual. There are rectal options, but it's not widely used or accepted in the United States. Another thing that we need to talk about when we're talking about pain is the nonverbal cues of pain. There are patients who cannot speak for themselves, so we have to be aware of these nonverbal cues, such as behavioral observations, crying, moaning, groaning, frowning, grimacing, furrowed brow, lip biting, and physical body movements, clenching their fists, their jaw, restlessness, guarding, and patients can become more withdrawn, wanting to stay in bed, not wanting to interact or socialize. We also have a saying called playing possum, and that's when a patient closes their eyes when you enter the room because they don't want to be bothered and they don't want to talk to you. Next type, so visceral pain, we'll do an overview of that. So visceral pain is the activation of the nociceptors in the viscera. The activation is a result of either stretching or distension of a body part, compression, obstruction, infiltration, inflammation, or ischemia of an internal organ. This pain is usually not well localized. It can be described as pressure, squeezing, gnawing, aching, or cramping type of pain. Examples of this kind of pain are things like jaw or arm pain when you're having a cardiac event due secondary to some coronary insufficiency, or shoulder pain secondary to metastatic disease of the liver or lung. There's also periumbilical pain, meaning belly pain. So in the mid-center of the belly, this can be a bowel obstruction or another type, or a type of cancer or some other type of pain. The ways to treat this kind of pain are opioids that we use in hospice are, we'll go over in more detail, but are morphine, Dilaudid, fentanyl, methadone. We also use steroids to help with pain. And of course, there's Motrin, ibuprofen, which is ibuprofen, or Tylenol. Next is somatic pain. And somatic pain is caused by tissue injury that typically affects the soft tissue, bone, joints, and the skin. And this type of pain is a direct infiltration, can be a direct infiltration of cancerous lesions. It can also be, and it's usually well localized, but it can also be arthritis, a fracture, which is a broken bone. And then you have cutaneous wounds, such as abrasions, burns, or abscesses of the skin. And then you can also have metastatic bone disease, meaning the cancer is spread to the bone. So this pain is usually well localized. There are, again, pain medications, the opioids that I talked about, steroids again, and topical treatments for the skin, which would be ointments, salves, hot and cold therapies. And we like to use ibuprofen or Tylenol for mild to, so on a pain scale, that would be like a 0 to 2 type of pain. Then we have neuropathic pain. Neuropathic pain is the injury to the peripheral nerves or central nervous system. And these can be lesions, tissue injury, or disease to the somatosensory system. This type of pain is usually described as a burning, numbness, tingling, shooting, stabbing, vice-like or electric shock type sensations. The pain can be intermittent, it can be constant, and it's usually associated with paresthesia. And paresthesia is the abnormal sensation of the skin, or dysesthesia, which means the abnormal sensation within the tissue. Common examples of neuropathic pain are sciatica, diabetic neuropathy, post-herpetic neuralgia, or even something like a cold sore on your lip. Organs that are affected could be the brain, so you have neurotoxicity, or even the central nervous system where you have spinal cord compression. There are people who experience neuropathic pain after chemotherapy, or people who have an amputation. They might have phantom limb pain or post-mastectomy syndrome. And those can be treated with things like tricyclic antidepressants, Cymbalta, Wellbutrin, anticonvulsants. Gabapentin is really good, or Lyrica for the neuropathic pain treatment. Steroids can be used for inflammation to decrease that inflammation. And then of course, hot and cold therapies have been used. Existential pain. This is an emotional, spiritual, or social type of pain. And I want to tell you a story about this because this is such an important aspect of pain management. I had a patient years ago who was raised Baptist, was considered himself pretty observant in his religion, but he was also gay. And he grew up believing that to be a homosexual, he would burn in, excuse my language, hell for all eternity. So he was really struggling with his death and coming to terms with his dying process and the fact that he was gay. And a chaplain worked really came frequently and worked with him on an ongoing basis to get him to a place of acceptance and understanding and to be at peace upon his death. So it's really important aspect. Many patients are, when they're dying, they fear dying. They want to know the meaning of life when it's a young death. Unresolved family issues can cause existential pain, fear of pain or losing control, fear of the unknown. Sometimes patients want to know what's going to happen to me. What does the dying process look like? And I try to be really open and honest with patients and tell them what to expect. I've even had a couple patients over the years with head and neck cancers, and their doctor told them they would suffocate. And so that's a huge fear, and just putting their fears to rest that it doesn't actually happen like that. Patients need a lot of reassurance. Some patients hold on to hope and pray for miracles, and that's okay. Hopefully they allow us to treat the physical pain while they're dealing with that existential pain. We also have patients that ask, why did I deserve this? Why did God do this to me? Is God punishing me? And we really rely on our chaplains and social workers to come and help with those patients because it's so important to get them to a place of peace during this process of dying. Oops. Okay, morphine. Morphine is a big word used in hospice. There's lots of truths and lots of myths about morphine. Morphine, honestly, is my medication. Sorry, there's a bug. My medication of choice. It is available, as you see here on the screen. It's available in liquid. That's given sublingually in small doses. It's given in pill form. It's given via IV. And we have short-acting options, immediate response options, long-acting, and it's a really great medication to use when patients are having pain. Some people believe that morphine kills. Morphine does not kill. I can't even begin to tell you the stories I've heard about that, but morphine provides comfort at end of life, and it's a great medication to bring comfort. Patients can be on anything from the smallest dose to incredibly large doses and still be breathing. And when patients die from when they're taking morphine, it's because the morphine has allowed them to relax and finally be at peace, and their pain is now managed. Patients out in the field have come in and they talk to us about fear of addiction. They're afraid if they gave their loved ones morphine, they might become addicted. And addiction is actually a mental dependence on medication. It's a drug craving, and it's more a psychological dependence than a physical need for medication. Patients have fears using morphine. Maybe I'm not qualified to give the morphine, and so I think a nurse should be the only one to give it, things like that. But morphine is actually an excellent medication. It's low cost. Other medications that we use in hospice are hydrocodone and oxycodone. These are pills, and these are given 1 to 2 pills every 4 hours. So you have to take it all the time. And it can cause stomach upset, nausea, vomiting, and it does have side effects of constipation, which all opioids do, but hydrocodone especially. And it can be addictive. So I try not to use that unless absolutely necessary. Actually, 0.5 of liquid morphine is equivalent to 5 milligram hydrocodone. And it works just as quickly, and you don't have to swallow to take it because it melts in the mucosa of the mouth. Methadone has a long and variable half-life. This is a hard medication. It can be as effective in 6 hours, but it may take as long as 190 hours to be effective. And it needs to be titrated up slowly in 5 milligram increments. And we here at Faith like to bring the patient on to the inpatient unit to monitor the methadone and to titrate accordingly, especially if we're changing medications around. We want them to be on the inpatient level of care so that we can manage that pain in immediate, because methadone does, like I said, take a while to build up in the body. But methadone is great for bone pain and bone metastasis. Dilaudid is the next medication that I want to talk about. It's more expensive than morphine. It's 4 times as strong as morphine. But we will use it if the patients require higher dosings of morphine, or if they have a morphine allergy or they're just afraid of that word, then we'll use the Dilaudid. But we usually convert patients who are on other medications to morphine when they come to the inpatient unit, or even at home on hospice. We try to use morphine as much as possible. Oh, sorry, let me go back. I forgot to talk about fentanyl. Fentanyl is, in hospice, we use it as a transdermal patch, and it comes in anywhere from 12 to hundreds of micrograms. And it's a patch that takes anywhere from 12 to 24 hours to become effective. And then it works for 12 to 24 hours after it's taken off. The problem with using fentanyl is we're not clear on the absorption that we're getting with the fentanyl. And if patients are what we call cachectic, meaning they're very thin and bony. The question is how much is actually being absorbed, because you need to get all the fat cells kind of filled before that fentanyl will be effective. So we don't really like to use it because we're just not sure how much is actually being absorbed by the patient. All right, next we're going to talk about complementary alternative treatments. There's lots of complementary alternative treatments for patients who are having pain, whether they're on hospice or not. There are modalities such as physical therapy, occupational therapy, there's art therapy, physical movements such as Tai Chi, yoga, chiropractic care, herbal remedies, oils. But for our purposes here today, we're going to talk about massage, which I consider gentle touch because it's not a deep tissue massage, it's a different kind of therapy. Music therapy, acupuncture, and pet therapy. And here at Faith on the inpatient unit, we use massage, music, and pet therapy on a regular basis. Actually, massage and music are on a daily basis. And I can't say strongly enough how much I appreciate these therapies. I was talking to the massage therapist earlier today, and we were talking about how she was able to prop and reposition a patient and bring their pain level down from an 8 to a 2 just by repositioning a patient. Massage therapy or gentle touch can be used to alleviate suffering that a patient is bedbound and they don't even realize that they're having pain, but they can something as simple as arm or neck tension or legs being swollen. Lymphatic therapy can be done. Music therapy is amazing. It brings lightning to the heart and to the head. It alleviates stress and just brings a sense of peace to the patient and to the room and to the families even. And if I could have a music therapist follow me daily, I would love it because it just brings such peace to and energy to the room. Acupuncture is great for alleviating physical pain as well. We don't use it here, but I do believe we used to, but it's a great form of alternative treatment. And then pet therapy is great for those who are missing their pets or just need that extra cuddles and love. And here at Faith, it's great because the families can bring their own pets for visits, which is just a wonderful thing. It makes patients so happy and brings such peace. And I know I'm supposed to go on, but I'm actually done. So again, I want to review as far as your objectives. So hopefully, and here's my references, hopefully here, you'll be able to name different types of pain and even medications that are used in hospice, understanding existential pain and non-treatment options for pain. And I am going to open the floor for questions. That's okay, Beth. I guess I talked a lot faster.
Okay.
Spoke a lot faster than I should
I
plan.
have some pretty good questions.
What about CBD oil massages? I think that would be great. Actually, I had a patient with female cancer, and she was having horrible muscle spasms to her hip. And her son had brought in some CBD oil massage cream or oil, excuse me. And yeah, he massaged her and that really helped her a lot. So I think it's great. Talk a bit about the physical and existential pain. So existential pain, that's a very good question because we do have patients with physical pain that will what we call chase that physical pain. And at a point, we realize that the existential pain is really more of the problem. once we feel like the physical pain has been managed. So we'll stay at that level of pain medication and really work to work on that existential pain. And music therapy really helps for that as well. Sandy, I hope I answered that question. If I didn't, please let me know. Can you talk about your experience with topical analgesics for neuropathic pain? Well, on it, yeah, thank you. I'm gonna just drink some water here. So topical analgesics, like the CBD oil, are great. I've had patients that have used liquid morphine and massaged that into their aching muscles and bones when they've had bone pain. And some people swear it works. I personally have never used it, but I'm open to all forms of trying anything when patients are suffering. We do have the topical analgesics like Voltaren gel. And of course, you know, when you're having, sorry. Oh, okay. Oh, thanks. Oh, that, yeah, that helps a lot. Sorry. So sorry, to get back to that, Cynthia, about the topical analgesics for neuropathic pain. I personally haven't experienced it other than the CBD and maybe some Voltaren gel. So I don't really know a lot about that. So if you want to expand on that, that'd be great. And I'm happy to share that information. Does morphine have side effects to remain aware of? Yes, morphine does have side effects like all opioids. There's always constipation as a risk. Nausea is also a risk. So we are aware of that. We do put patients on what we call a bowel regimen anytime they're on an opioid, whether it be hydrocodone, fentanyl, methadone, morphine, Dilaudid. We will have them on a bowel regimen. And the bowel regimens consist of whether it's something as easy as Colace, which is a stool softener, to bisacodyl suppositories, or Senna, or even lactulose and Miralax. We use those. As far as the nausea, we do, if they're in the inpatient unit, we do IV medications. And if they're at home, we do have oral medications that patients can take for side effects of nausea. Hope I answered your questions there, Lawrence. And how do we differentiate between anxiety and pain? So it's a really good question. When patients are having uncontrolled pain, they do tend to be stiffer, more rigid, and having anxiety. So we do treat anxiety with medications such as lorazepam or alprazolam, which are anti-anxiety medications. And we are able to differentiate between the pain and the anxiety. But we do, in conjunction, we will use lorazepam and morphine, because like I said, I like to use morphine as the main medication. And we like to use those together because it helps to relax a patient for the pain medication to be more effective. And I call it like my cracker and cheese conversation, because crackers are great by themselves, cheese is great by themselves, but when you put it together, it's excellent. And so lorazepam and morphine together work really well hand in hand. What assistance can help an elderly 93-year-old with chronic kidney disease? The kidney lab score of 23. So I'm not really sure what you're asking me there as far as what assistance can I offer. A patient with chronic kidney disease means they still have some kidney function left. I don't really worry too much about the kidney function with medication, because the goal of care is comfort at end of life. So we're not so focused on the numbers as we are on the patient's verbal or nonverbal cues of pain and anxiety. That's what we go by. So a 93-year-old, we would still be worried more about the anxiety and the pain. Good question. Okay, how do I view the role of the social worker in pain management? Oh, so social worker is great for the existential pain management. Our social worker is invaluable. They help with helping families who need paperwork filled out, with placement, excuse me. And a lot of that existential pain, once that's alleviated with the help of the social worker, we can then focus on the pain itself. So that's a really good question. I hope I answered that in a good way. Do I have any stories to share? Oh, yes, thank you, Michael. So I had a patient years ago. It was an older gentleman who his wife was caring for him, and he had, I believe if I remember correctly, it was prostate cancer, and he was having horrible nausea and vomiting, and he was on fentanyl for pain. His pain wasn't well managed, and his nausea and vomiting was so bad that the only thing he could tolerate and keep down were tomatoes for whatever reason. So I recommended stopping the fentanyl patch and trying him on some oral medication along with some nausea medicine. And at my next visit, believe it or not, nausea and vomiting were gone. His pain was well managed, and his wife was able to get him eating and to get him up out of bed and into a chair. So it's really important to find the right medication for the right patient to help manage their pain, and being aware of the side effects of those medications. Are there any particular requirements, certifications to be a music therapist? Yes, there are. And Beth will send you that information because music therapy is amazing. All right, Sandy. Some doctors recommend methadone for pain for renal failure since it's processed via the bowel. Methadone is great for pain management, and we do use it for visceral pain as well as bone pain. I can't say enough about methadone because if it's used correctly and we are able to remove other opioids from the patient's system and just concentrate on getting their pain managed with methadone, it's great. So I don't know about renal failure in particular, Sandy, but I do like working with methadone. I trust it, and it's a great medication. Okay, this is a long question. Okay, so I'm going to read it. Here's the anthropological question of the day. The Navajo have healing way family ceremonies at life passages like death. Cultural approaches have been more broadly considered in recent years. Has any area hospice ever looked into something parallel to help both the dying person and their family and other close ones? There's a certain power to having loving, supportive people gathered. Western societies gather, but they don't make it an impactful event usually until after death gatherings. So actually, there are doulas that work in hospice to help. So just like we have birthing doulas, there are actually doulas to help in hospice and end of life to provide that environmental peacefulness within the death, whether the lights are dimmed or they like bright lights, or family members being there, music being played, candles or incense, or whatever that environment looks like for that person who's dying. So we try to make it peaceful here. Sometimes we'll have a patient that we're removing from a vent or a breathing apparatus, and we'll have massage therapy, we'll have social worker, chaplain, music therapy going on, all of that surrounding the family and the patient during that time to make it a really peaceful healing process in the dying process as well. All right, next question. Is it correct to assume all hospices use an integrated approach to pain management with physical and alternative therapies? And do patients need to search for hospices that do so? That's a good question. I would hope that all the hospices out there are using an integrative approach for pain management with the physical and alternative treatments. I sure hope so, because it's invaluable to have those alternative treatments available instead of just focusing in on pain. Yeah, so I hope so. That's a good question, Erica. Anyone else? I know we're done early. So I'm going to let Beth come back. Thank you all, and I hope you enjoyed this presentation.
Let's see, close this out. Well, thank you guys so much for attending today. I know I had a couple of people on the chat also state that they didn't have the documents that were needed for today. So feel free either to email me or just shoot a comment on the chat feature and I'll get those out to you. I'm just checking the chat comments again. Everybody's saying very helpful. Thank you. Thanks. Really helpful information. Okay, so we're going to go ahead and end this session today. A huge thank you to Sue. And again, thank you guys for your continued support with all these educational programs. And I will be working on a couple of more for the upcoming months and in the fall. So just be on the lookout for my emails. You guys enjoy the rest of your week and we will talk soon. Bye-bye.